Good morning to all of you on an early Sunday morning, and very nice of you to get here as early on a day when we all should be sleeping. But it's nice to see you back, and we have some new people who've come just for today. We have actually a very unique morning, something that really hasn't been done before. So we're very excited for what you're going to be hearing, which is really about 3 different kinds of treatments. And we have 3 of the leading experts, I'd say, in the country and the world on these treatments who will be talking about their treatments around a specific case, and then dialoguing amongst themselves for us to participate in on how these treatments address different issues in each of these therapies. So it's really something that we think is quite unique, and we're so very appreciative of our presenters who have joined us in this unique opportunity and have actually had to do presentations that are quite different than what we normally have. Then we also will have our family panel, which I also believe is something that you'll long remember, because when you hear from people who live with the disorder, whether it be from having the disorder themselves or because they have a family member, the way it impacts lives really is something that for many of us stays in our hearts, probably more than any of the data that's normally presented. So we look forward to having that family panel as well. It's now my pleasure to introduce the moderator of this part of the program, Dr. Ken Silk. Dr. Silk is more than just a professional to NEA.BPD. He's been a real true friend to us, and as I said to him this morning, he's the kind of person that when we do something with him, he washes the windows with us. He doesn't expect someone else to do it. He really gets in there and jumps in and does what needs to be done. So we are very grateful to him. He's the science editor of our website that we are just launching, which is bpdforum.com. And he also is someone that we've co-sponsored a conference with on his home territory in Michigan. So it's my pleasure to introduce Dr. Ken Silk, Director of the Personality Disorder Program and Professor at the University of Michigan. Thank you.
Thanks, Perry. I want to say something about yesterday, but while I'm doing that, you can also, if you want to, briefly take a look at the case, which is really right after it's in the second half of the booklet. It's the first thing in today's part of the program. The speakers were asked to at least try and reflect back on the case, or to actually build the aspects of their presentation around the case. It's a generic case, but I think it has a number of different affective and behavioral points that I think are really important, and hopefully they will touch on issues that if you're a consumer or if you're the family of a consumer would be familiar to you. And then at the end there'll be a round table, and my job will be to get these folks to disagree. I've done too many round tables when they say, well, it's all really just the same thing. So I'm going to be provocative. My job will be to kind of try and get people to talk about the edges of where these things kind of, maybe they slide against each other, maybe not too much friction, but I don't want them to blend. Not that everybody's a purist in one way or another, but for you to have the distinction made more plain to you. I want to say something about yesterday, because Perry knows I was getting kind of anxious as the day went on, or when the discussion went on, because I felt like it got, I don't know how many people were here yesterday. How many were here yesterday? Oh, good, okay. Then I'm not wasting your time, hopefully. That I got concerned that it got too scientific at the end. And, you know, it was really interesting to hear people chat about the amygdala and the ACC and how you would pick this person and that person. But it's also probably the part that drives all of you crazy about academics. It drives me crazy about academics as well sometimes. So I tried, and I slipped a question in there, which was basically, so what does this have to do with me if I'm a consumer? And then we went on, and they were talking about some medications, and I made a comment, and I want to kind of modify that. I made a comment that there were only 20 well, we had studied 21 placebo-controlled, randomized controlled trials of medications. There are many, and I want to go and say there are many more trials than randomized controlled trials, not necessarily placebo-controlled trials. There are many other randomized controlled trials that I didn't mention. So I didn't want people to think, my God, only 20, what does that mean, what's going on here? But I was trying to make a point that I thought there also needed to be some way we coordinated the findings from the trials so that we can build, and so that if I do something and Frank does something with the same meds, but we use different measures, you know, how do we parlay that into something that can be better for people to understand and maybe make some sense out of. So, but what I do want to emphasize is that back in 1980, when the borderline personality disorder and whatever its future name might be became an official diagnosis, there's been a tremendous amount of work that's been done on borderline personality disorder. There's a tremendous amount. Now, if you're struggling and you haven't gotten better after 20 years, or you have a family member who continues to be suicidal, maybe that sounds like an academic point, and, you know, well, this guy can say that, but he doesn't really know what it's like to live with the disorder. I hope that to some degree we do, but from where we sit, there really is progress being made. And all of the stuff about neuroimaging, and I thought that some of the talks were absolutely wonderful, and I hope were very helpful, because about how people are trying to figure out, well, what parts of the brain seem to be involved with some of the stuff that's going on. And the work, particularly in the last 5 years, has just been exponential. That line just goes straight up, and it gets better and better. And there are now studies looking at those neuroimaging issues before and after some of the treatments you're going to hear about today. Sabine Herpitz has done a small study with DBT and using fMRI. So that they are coming together, and I didn't want people to think that, well, really nothing has happened, because there's been a tremendous amount that's happened. And here's my segue. So and yet during all of this, and you heard the talk about medications, and that medications can be somewhat helpful some of the time. You know, the underpinnings of the treatment of this disorder have been psychotherapeutic underpinnings. And the most exciting thing is in the last decade, and particularly, I guess, if you look even in the last 3 or 4 years and you just read the archives of Journal of Psychiatry, which is like, you know, the Ritz of psychiatric journals, you know, there have been studies randomized controlled studies of these psychotherapeutic treatments that you're going to hear today. And what you will hear is that in each and every instance, there's data to show that these can be helpful. Some may be helpful for some sets of symptoms, more than for other sets of symptoms, but that they're all helpful. And maybe we can get people to talk at the end, why might they be all helpful if I do my job in showing how they're different, then how come so many different things can be so helpful? But what's been the core of the treatment, psychotherapy, is really being refined, it's being manualized, it's being tested, and the results are very, very encouraging. And before we go there, only one other thing that Antonio said yesterday about, well, a lot of it depends upon if you want to get better or get through borderline personality disorder, a lot of it depends upon where you live. And to some degree, she's right that certain cities have more resources than other cities, but the implication that Antonio made with Mary Zanarini's studies, which show that after 10 years, 80% of the borderline folks are no longer borderline by diagnostic criteria, she implied that all of these folks were still being treated at McLean's in Boston, and that's not true. Mary's patients came in, and they were evaluated initially in a hospitalization, and then they went on to get treatment. Now, they may be getting treatment with people from McLean's or trained with McLean's, but it wasn't a treatment study. It was a natural history study. It was a follow-along study. So folks are in the hospital, they went their own way, and Mary touches base with them every 2 years. So that's another encouraging thing here. That you know, it isn't some rarefied thing that what's going on, but proper treatment and proper psychotherapeutic treatment is really where I think the rubber hits the road. So with that said, and I'm sorry I took so long, I want to introduce Frank Yeomans, who's the Director of Training in the Personality Disorders Institute and Clinical Associate Professor of Psychiatry at the Wheel School of Medicine here in New York at Cornell. And when we had the meeting out in Michigan, I found out, which is always nice in these days of economic trouble in Michigan, he loves cars, even American cars. So, Frank?
Thank you, Ken. It's nice to have one's real points of achievement pointed out. And I wanted to thank you and Perry and the rest of NEA.BPD for organizing this. You folks do a terrific job, and as we know, there's always more to be done. So I hope there'll be increasing family connections set up. As many as there are, we need more. We could use one in northern Westchester or Dutchess County right now. I just asked Perry, and apparently we're not that far into upstate New York yet. In terms of getting information about BPD, I would recommend going to the Borderline Personality Disorder Resource Center website or calling them. This is affiliated with our Personality Disorder Institute at the Weill Medical College of Cornell. It's a really great resource for information and trying to find resources for treatment wherever you may be. As Ken pointed out, I guess Antonio New said, the treatment depends largely on where you are, and there are large underserved parts of the country. So we're doing our best to try and find resources in those areas that don't have so many. I'll advance for the sake of time. The group we work with is listed here. I won't be able to go into individual names, but I just want to emphasize it's a really terrific interdisciplinary group. We develop our treatment, we refine it. As Ken said, there's always an ongoing evolution of the process of refining one's treatment, because no treatment is perfect yet, probably never will be. As you'll hear in the course of my talk, the whole idea of perfection is a dicey one that we think is problematic within borderline personality disorder. So we're always perfecting, evolving, and this team is a great one to work with in terms of treatment development, clinical practice, teaching, and research. Now, I'm going to be talking about transference-focused psychotherapy. So first, I'd like to give a definition and a description of that. Now, it's the first manualized psychodynamic treatment for borderline personality disorder. I want to say a word about what psychodynamic is. Psychodynamic is a treatment that stems from the psychoanalytic tradition. The psychoanalytic tradition, of course, is Freud and all of his followers. And whenever I talk about this, or not whenever, but depending on the setting, in some places it's like I'm coming from the Museum of Natural History of Science, because it's treated like something that had its day, and that's it. But we try to keep it current. And I think there are a lot of problems with the old analytic approaches, but our point of view is not to throw the baby out with the bathwater, but to take what's good and leave behind what wasn't so helpful. So the term psychodynamic, which people always throw around, is one whose original meaning is often forgotten. And I'd like to remind us of that because it really helps understand the treatment approach. Psychodynamic means the mind in flux. Psycho is the mind, and dynamic is in movement. And I think all of our minds, yours, mine, our patients, have ongoing collisions, if you will, of different forces, desires, prohibitions to desires, urges, the influence of external reality, which sometimes doesn't let us follow through with our urges. So we see the core of borderline personality disorder as a conflict within different forces in the mind, rather than a set of symptoms, which are just objective symptoms that have to be treated one by one. You know, medicate the depression, for instance, take care of it that way. I'll explain more about this later, but I want to emphasize that we see conflict within forces in the mind as the core of the underlying symptoms, the depressive symptoms, the mood symptoms, the impulsivity, the relationship problems, and I hope by the time I'm through with my half hour, some of that will be clear. Now, we had to do a manualized treatment for two reasons. One is that psychoanalytic or psychodynamic approaches were famous for being vague and imprecise, so we wanted to do something that was replicable and could be taught from one person to another, and one could practice it with some sense of the reliability that the same model is being carried out in different practitioners' offices. But it's also necessary to have a manualized model to do research. And to be current, one has to do research on one's psychotherapy model these days. Now, some people say, why do we bother working at this level? Because some people contend that it's a little bit more complex or more in-depth than some of the other models. I would say for two reasons. One is, in our most recent research, we've shown that compared to two other treatments, TFP was the only one that increased an individual's capacity for reflective functioning. Reflective functioning is a concept also called mentalization that's becoming very popular these days, and it has to do with an individual's ability to accurately assess what's going on in their mind and what's going on in the mind of the people they're involved with. And we find that in borderline patients, this capacity tends to be pretty low at the beginning of treatment. There are misconceptions, a lack of contact, a lack of appreciation of one's own mental states and of the mental states of others. So we think this increase in reflective functioning is important as part of the treatment. And also we feel that the treatment, working at a deeper level, leads to what we call psychological integration, or a better sense of who one is, a more coherent, complex, rich, and less conflictual sense of who one is, which we think is really the core to well-being in an individual. So continuing with this brief description of TFP, it's based on what we call an object relations model, which I'll go into in a minute, and it focuses attention on three levels of communication, not just what the patient says, but the patient's nonverbal communication and also the countertransference or the therapist's own internal reactions. And we think that it's the latter two channels that provide the most information in the early stages, because generally people know what they say, and what they aren't aware of comes through nonverbally and through the actions, through the reactions they provoke in others. Our aim is at changing an underlying personality structure. I'll define personality structure as we do in a minute, and that we feel is the best way to come to the truest resolution of problem behaviors and symptoms. And even though I won't have time to go into it this morning, we've shown efficacy of this model in 3 empirical studies to date. The first one using our patients as their own controls. That's called a pre-post study, where you study the condition of the patient before the treatment and after a year of treatment. Then we did a non-randomized comparison of TFP versus a treatment as usual. And more recently, we published a randomized trial of TFP, DBT, and a supportive psychodynamic therapy. Okay. Now, just a word on a rather complicated question. Who is TFP for? We feel it's not just for borderline personality disorder patients in the narrow sense, but it's for this whole range of patients. This slide can be a little confusing, so I'll summarize what you need to know, and I'll begin to make a connection to what Ken wants us to do, which is how do we differ with other treatments. So consider this a map of the different personality disorders. Borderline personality disorder is right smack in the middle of it, but there are a lot of other personality disorders like histrionic, narcissistic. And what I would ask you to keep in mind for the purposes of this morning is that in our model of classifying the different personality disorders, the vertical axis, although on this slide it says mild severity at the top and extreme severity at the bottom, I think you could also see that vertical axis as lesser levels of aggression at the top and stronger levels of aggression at the bottom. And this is something I think may distinguish TFP from most of the other treatments, our emphasis on the role of one's own aggression. A lot of treatments emphasize the patient's role as the victim of aggression, but we feel it's a little more complicated than that. Back in the old days, people used to come to Otto Kernberg, actually usually not come to it, but say it, come to him, but say it behind his back. They'd say, oh, Otto Kernberg, he's just obsessed with aggression. That's his thing. So one day I said to him, I said, Otto, are you obsessed with aggression? And he said, that's a misconception. I'm only obsessed with aggression to the extent that it interferes with libidinal expression, which in common English means the ability to love. So in any case, I'll talk more about our attitude vis-a-vis aggression, but I'm also pointing to this slide because we talk about borderline personality disorder as though it's one thing, and yet all of us who specialize in it know it comes in different varieties. So in my experience, and we're beginning to see this through our research, there are some patients at the higher level where the aggression is less intense, where, to put it simply, you can say these patients are looking for love in all the wrong places, or looking for love and assuming it's not there, because they really want to connect to someone, but they're so afraid of connecting, they're so sure it's going to lead to pain and suffering, that they throw in all these things that interfere with it. And you've got to help them see what their fears about connecting are, to open up that ability to really relate to others in a close level. But we see at the lower end of this set of diagnostic categories, patients where the aggression is more primary. Some people actually like to exert their aggression. Some people get a kind of a pleasure out of triumphing over being on the top, and so on and so forth. So depending on whether your patient is somebody who's looking for love in all the wrong places or somebody who really likes to triumph over the other, your interventions may be different. And that's something else we might refer to later on in the comparison. But in any case, what are the key concepts? I want to get through some of these concepts and then talk very briefly about some of our techniques. We see identity diffusion as the core problem. Underneath the affective, emotional problems, underneath the relationship problems, underneath the behavioral problems, the impulsive acting out, we see a split and fragmented sense of self, which is also distorted and superficial, and the split and fragmented sense of self corresponds to also fragmented views of other people. I'll explain that in a minute. This leads to difficulty reading others, difficulty knowing where others are coming from in reality. It also leads to difficulty understanding one's own emotional states, a lot of confusion about that. So because of that, these people use what we call primitive defenses. I won't get into that right now because it's a sort of analytic term. But it leads also to variable reality testing, to distortions, so that people might perceive another individual as different from what they really are. The classic example when I worked in the hospital is almost every patient would come onto the unit, they'd come to a meeting and say, I can't stand it. I was walking down the hall and I can tell this person hates me. And we'd say, well, how do you know they hate you? And they would say, well, I said hello to them and they didn't say hi back, which of course is not a nice experience. But we'd say, well, you know, are you sure they heard you? Because a lot of these people kind of mutter hello because this is where the fear of rejection sort of creates what they fear. They kind of mutter hello because they're afraid that they won't get the response. And then, so is it possible the other person didn't hear you? Is it possible the other person was talking to somebody else? Is it possible the other person is totally inhibited themselves? So the distortion is the conviction, based on very little evidence, that the other person hated them when there may be other ways to perceive that small interchange. And if little interchanges like that can create such emotional impact, imagine a day full of those things. So what are our goals and objectives? The first, and this corresponds to kind of two fundamental phases of TFP, we have to contain suicidal and self-destructive behavior. So in the first 6 months of treatment, usually it's about setting up conditions of treatment where those things get under control. Then we get to do what we really think is the core of the treatment, which is the resolution of this identity diffusion, this fragmented sense of self. And we do this through fostering reflection on mental states of self and other, by exploring feelings, motivations, and beliefs in the context of the therapeutic relationship. That's where we get to the transference. We think people are going to understand something if they're observing it as it's happening. This is a therapy that's not just about ideas, but it's an experience. One of the things about psychotherapy these days is that there's a big debate. How much is psychotherapy the actual interventions the therapist makes, the comments, the interpretations, the teaching he or she does, and how much is the effective psychotherapy due to the experience of the relationship? We think it's both. And what we emphasize is that somebody, we believe, is going to change more if they're experiencing the affect that's problematic, the emotion that's problematic, while they're thinking about it, because then you've got the whole thing right in front of you. So what are the characteristics of this treatment? Structured by a treatment contract that sets up the conditions that hopefully contain the acting out. When the acting out is contained, we expect that the emotion in the room with the therapist is going to heat up, because then all these emotions and affects that were difficult to tolerate, they're no longer discharged into acting out, but they enter into the room and we can observe them. 2 sessions a week, outpatient, minimum 1 year, often longer, but we found from research significant changes can be made in a year. Focuses on the immediate interaction, can be augmented by other treatments. We don't think it's the be-all and end-all. Some people need 12-step programs, eating disorder programs, other kind of interventions, family interventions. And it can include contact with the family. It's not a totally sealed-off process like some of the older analytic treatments were. So now I have to speed up. I see I have about 15 minutes left. This is what we base our model of the mind on. We feel that psychological structure is based on internalized experiences of self and other. That in growing up, infants take in experiences that have a high emotional charge, experiences of frustration, fear when they weren't cared for, and experiences of nurturing when they were cared for. And we feel that in the course of development, all of us pass through a stage of what we call a split organization. Because before individuals achieve what's called object constancy, which is to realize that it's the same object you're dealing with, whether they're frustrating or gratifying, that objects, in other words, others, have complexity to them. We believe that everybody in the first couple of years of life has a mental structure like this. Experiences are internalized so that they're all bad or all good. They're all frustrating or painful, or they're all gratifying and satisfying. And what happens in usual development is that these two extremes merge into a sense of self that includes positive and negative characteristics, and a sense of others that also is more complex and involves positive and negative characteristics. The problem we see with patients with borderline personality disorder is that they don't achieve that integration. This is the famous splitting, where they can go from hot to cold in just a second. And it's very confusing to them, and it's very confusing to the people around them. By the way, since we feel the mind is in flux, we also feel that any one of us under sufficient stress can regress to this kind of thinking. This may happen in wartime. This may happen during the World Series. This may happen when you're falling in love, and all of a sudden the object of your love is totally perfect. The real challenge of love is not to become infatuated. That's easy. It's if you still love the person the first time you notice they have bad breath. Can you integrate that? So in any case, we don't think there's such a total discontinuity between the borderline experience and our own, but we feel anybody can kind of go back and forth. So we try to get people to go from this split organization to this integrated one. The interesting thing is that there are some resistances, and this is another difference perhaps with the other models, because we believe there are psychological forces that the patient isn't aware of. And one of the things that makes people not want to give this position up, this mental organization up, is what do you got here? On one side of this, you've got perfection. On one side of this, you've got a world where there is a Santa Claus. On one side of there's a place where there is the white knight who can make everything better. I can't tell you how many of my patients really think that for all the difficulties they've had, something is going to happen. Their life will become perfect. It's hard to give that up. And one of my patients, after about 2 years, or 2.5, said, you know, you've helped me a lot. I don't fight with my husband. We don't have the terrible fights and brawls we used to have. And, you know, my symptoms have calmed down, but you've also taken something away from me. I used to believe I would find the perfect love, and now I know that doesn't exist. So sometimes I think of borderline patients as the ultimate romantics. They think they're going to find ideal love, and yet it gets them into trouble all the time. So how do we do this, bringing somebody from the split, fragmented organization to the integrated one? Well, let me jump ahead a little bit. We assume that in the split mental structure, a person functions according to different dyads, different representations of self and others that are in their mind and not connected to one another. This is why anyone who's had a lot of contact with a borderline patient knows that you can be the apple of their eye in 1 second, but a little bit of a frustration, and you become the object of intense hatred or fear. It just goes from one thing to another. So what we want to do is to become the person who is the object of the projection of these internal representations. We want to offer ourselves, just like the camera or the projector is projecting on the screen, it's now projecting onto me. I want the patient to project onto me what's in their head so they can get to know about it, because they tend to think it's real. I'll give you, they do. I'll give you a brief example. Patient referred to me after a suicide attempt. She was being discharged from the hospital, and for the first 2 or 3 months of therapy, she told me that all of her depression and suicidality came from the fact that her husband was a sadistic monster. For all I knew, that was true. How do I know? I mean, that might have been exactly true. We feel you can get to know what the real story is by what happens with you. One day, I was 3 minutes late for a session, and I'm obsessional enough to really believe it. I'm obsessional. I know I was just 3 minutes late. So in any case, I go to the waiting room, and the patient is rushing out the door of the waiting room to the parking lot. So not being a traditional analyst, I ran after her and said, "What's going on? We have a session." And she jumped into her car and sped away. Now, I wasn't going to speed after her. That would be a little too much even for me. But I did wait 15 minutes. I knew it would take her to get home. I called her at home, and I said, what's going on? And she said, "I discovered what I always knew." Remember, this is like 3 months into therapy, and she's been a generally cooperative patient. I said, "What is it you've always known?" She said, "I've always known you hate me, you don't want to see me, you want me out of your practice, and that's why you kept me waiting 3 minutes." Now here, we agreed about the fact I was 3 minutes late, but then her interpretation, I would argue, was something triggered. It triggered the activation of an image that's very powerful in her, people who don't like her, people who don't want to have anything to do with her. And because she acts on that triggered image, that gets her into a lot of trouble, and that creates a lot of personal misery in her. So this is another possible difference with some of the other treatments, because I think that, you can correct me, Alan, DBT has a lot to do with how to modulate your responses to triggers, which I think is very important. But we put as much, if not more, emphasis on what did the trigger trigger? What did the trigger provoke? What got activated, and how to understand it, and how to see that it may be distorted. So in any case, we're all about the idea that perceptions may be inaccurate and extreme. So what happens in this treatment, as I said, we get these distortions to get played out between the patient and us, and we don't try to correct them. A lot of supportive therapies would say, "Look, come on. What makes you think that being 3 minutes late means I hate you?" You try to reason. We don't think that helps. We think what helps is to get the patient to observe more fully that internal image that's determining their experience, and to begin to question it. So I didn't say to this woman over the phone, "Oh, come on, 3 minutes doesn't mean I hate you." I said, "That's really interesting. I'd like to hear more about this conviction you have that I hate you, and I don't want to have anything to do with you. I think it would be important to come to the next session so we could look at that." She said, "Why would I come to a session with somebody who hates me? The belief is so real, it's determining her actions." So I said, "Well, that's a very good question, but if I hated you that much, why would I be encouraging you to come to the next session?" And she said, "That's confusing. That doesn't make any sense." And I said, "Well, that's when we need therapy, when things don't make sense." So she came to the next session, and we began to explore this. This gets us actually to the next slide, because, again, I want to talk a little bit about aggression, since that's one of the points we probably differ on. As psychoanalytically inclined people, but I think, from my point of view, just as a human being, I think aggression is part of human nature. I think it's an evolutionary process, and people had to sort of develop a little of that to survive. Without aggression, you would have just been stomped on by other people or animals or what have you. But the other thing is that aggression isn't necessarily a bad thing. Aggressive drives are assertive drives, they're competitive drives, they're what leads to achievement and creativity. So I think it's wrong to say aggression is bad, you just stamp it out. So what we feel happens is that, even though I haven't had time to mention it, we all know that a lot of borderline patients have had experiences of abuse. Now, therefore, a lot of people say it's like PTSD. The person was abused, they become, they internalize the role of victim, and they're afraid of the world because they think everybody's an abuser. We add a little bit to that in saying the person may be abused, and they may have that image of a real abuser, but it gets more complicated because their own aggressive drives, their own angry, hostile feelings or assertive feelings, then begin to organize around this internalized image of the abuser so that they confuse their own aggressive strivings, which might be perfectly legitimate and which they, if they acknowledge they could manage to make better achievements in life, they begin to think anything assertive and aggressive is bad because it's all wrapped up in this little seed of the image of the abuser. So I'll give you one example here of a patient, because this is what we call the oscillation of the diet. Patient walks into my office. She happens to be a social worker. Very wonderful that she got through social work school with all her symptoms and difficulties. About 6 months into treatment, she says, "May I borrow this book from your shelf?" Now, since I'm doing an exploratory therapy, my mantra is I have to understand something before I act. So I didn't, not like I wouldn't have given her the book. I hadn't decided. But I said, it's really interesting. You haven't asked me for something direct like that. I wonder what it means. I thought maybe she's feeling more comfortable with me or what have you. So she reacts to that. Again, a trigger. Says, "You fucking son of a bitch. You wouldn't save me if I was falling off a bridge in front of you or if a bus was going to run over me. You're just like everybody else." This, that, the other thing. And she got up from her chair. She started pacing in front of me and waving her can of Coke like she was going to throw it at me. So I was a little anxious, but this is what theory is for. Theory helps us when we get anxious. I said, "What's going on here?" I said, "Oh, this is a dyad and it's getting reversed." This brings us back to the principle of reading the nonverbal behavior. So I said to her, "Excuse me," she was going on and on, really angry and yelling at me. And I said, "I've got a thought that might be helpful if you're interested in listening." She said, "What is your stupid thought?" So I said, "Well, if you were a person walking by this office looking in the window, what might you observe?" And she could get enough clarity of mind to say, "Well, I guess people might think I was mistreating you." And I said, "Well, that's the secret." And then she said, "You're telling me I'm bad." I said, "No, I'm not telling you you're bad. What I'm telling you is you've got a capacity to be angry, you've got a capacity to act aggressively, and that's fine. We all do. There's nothing to be ashamed of. The problem is that for all sorts of complicated reasons we can look at, you don't think you have a right to that. So here you are thinking that I'm abusing you, feeling very justified in your reaction, but becoming kind of abusive to me. And that's fine if you want to do it, but I think you'd be better off to have an awareness of it, then you get mastery of it, you can use it more effectively." So we try to get somebody to own that in them rather than to deny it and act it out. So, having said that, I'm actually going to jump ahead to, here's a list of readings. I can put that up later. How many minutes? 2, 3. Then I'll get to the comparison. I'll skip all this other stuff, and I'll get to the comparison. The different therapies, how different? So one issue is, should the accent be on deficit or conflict? A lot of treatments of borderline patients think they don't have certain abilities. We think that's true, but they also have an internal conflict. We see conflict and deficit. Are borderline patients capable of symbolic thinking and able to use interpretations? That's more a debate between us and Peter Fonagy, but it might come up here today. Is the problem of aggression one reaction to trauma and mistreatment with possible dissolving of regression? It just goes away when the person sort of gets to be thinking more calmly. Or is it a primary psychic force to be integrated, which is the way we see it? As I've already said, the focus Should the focus be on the meaning of the trigger or how to deal with the intensity of the response to the trigger? Should the focus be on emotional regulation versus psychological integration? We could keep that in mind. I think we need both. And what about life goals beyond symptom controls? I think our research, because of the limitations of research, has shown mostly that people can control their symptoms. But what about becoming human beings who can get as much satisfaction out of love and work and creativity? Given the above, different concepts in different models, like we use the concept of projection, which is what I've been describing to you. A person has a part of themselves that's not acceptable to themselves. They project it on the outside world. They react to it as though it's outside of themselves. They can never quite get beyond it then. So this leads to different techniques. We use our countertransference, the reaction we have personally a lot. Then, if there are differences in the treatment, how about the possibility of a sequence of treatments? You know, one treatment to deal with this part of the puzzle, and the next treatment to deal with another part of the puzzle. Or are there subtypes of borderline patients, really? Are there some patients who would respond better to one approach, some patients who would respond better to another? We have the whole challenge of subtyping borderline patients and seeing if certain ones might be better off in certain treatments. Now, I have a few slides about the case, but shall we save the case for the overall discussion? All right, so I'll end there.